join us, and this is our part 2. Today we're going to be covering some subjects that are near and dear to all your hearts: gonorrhea and chlamydia. For the most part, we're going to be covering that. We also have an update from our state lab. Christina Langer is going to join us for that. We're going to have a panel discussion on EPP use, which I hope you are all going to be very interested in. And that's going to be facilitated by Dr. Sosa. And we'll have some updates on chlamydia, gonorrhea, and other STI updates from the STD guidelines, recent publication of the guidelines from Dr. Zun Wangu. So we're going to have a chock full agenda today. I hope everyone will be attentive. We're going to take some breaks in between. It's not on, we have about 9 o'clock and a little after 10. So you'll have a chance to go grab your coffee or tea, whatever your preference. So we're going to get started first off with some epidemiological profiles that's going to be provided by Ava Nepal. Ava, are you on? Okay, I don't know that Ava's on just yet, but I do have just a couple of housekeeping pieces to remind you of. Let me just advance my screen here. So as with all of our virtual meetings and conferences that we've gotten used to since the pandemic, just make sure that you have all of your other applications closed while you're viewing this presentation. The chat box is where we're going to be providing some opportunities for you to provide questions while we're doing the presentations. That's in the lower center part of your screen. Just make sure that you mute while the speakers are speaking. And that is in the lower left-hand corner of your screen. So just make sure that that's checked while the presentations are going on. And if during our presentations or the conference you have any questions, any technical problems, any issues, you can email Janine Dyer at janine.dyer@mass.gov. So just reach out to her if you have any problems. And I'm just going to check in again and see if Ava has joined us yet. Ava, you on?
I do see, hi, it's Janine. I do see Ava's name listed as a participant, so maybe she's just onboarding.
Okay, all right. She might be having some technical difficulties, which is not unheard of these days.
Okay, I'm now able to unmute. Yes,
There
I am
we
here.
go. There we go.
I couldn't unmute. So.
All right. I'm going to stop sharing my screen while Ava will pull up her slides while I introduce Ava. So Ava is somebody I'm sure all of you know, most of you know. Ava Nepal has worked as an epidemiologist with the Connecticut Department of Public Health since 2001. She joined the Sexually Transmitted Diseases Prevention and Control Program as the DIS supervisor for the Hartford area in 2017. In addition to her experience in infectious disease surveillance and investigation, she is a skilled program evaluator and developed the DPH socio-demographic data collection policy. Ava earned a bachelor's degree in human biology at Brown University, a master's degree in medical anthropology at the University of Amsterdam, and an MPH degree at the University of Connecticut. She is also certified in public health since 2008. So Ava, please take it away.
Okay, good. You just confirm for me, folks, that you can see my screen, my presentation.
Not yet.
Okay, hang on. I will reshare. Okay, it looks like it took this time. Okay.
Let's see. There we go.
Okay. All right. And I'm going to turn my camera on because, you know, I don't think that you want to talk to my DIS background. Okay. So now that you can see my screen, I want to welcome you all back. For those who are returning, for those who had technical difficulties and couldn't join us last time, thanks for coming. Today I'm going to present to you data on our friends chlamydia and gonorrhea, with which I'm sure many of you are familiar. Okay, these are our learning objectives for today. Okay. So with respect to chlamydia and gonorrhea, the DPH STD prevention and control program does not have the capacity to do the level of investigation that we do for syphilis, which I talked about last week. In the instance that there is a particularly complex or a severe case, we will try to locate a person and get them in for care. There are two cases that come to mind. One was a person who had had a recent DNC, and it was discovered after the procedure and after the person had left that their gonorrhea tests had come back positive. This person had been recently released from the Department of Corrections, and so there was difficulty from the clinical site to locate them. So we used our locating resources to find this person. I spoke with her myself, and we were able to get her and her partner in within a day in order to get proper treatment. Another case we had was a minor who did test positive for gonorrhea, was not responding to the provider request to come in. And this person didn't just have gonorrhea, but also had other severe comorbid medical conditions. So in that case, we did assign a DIS to try and locate this young person. Unfortunately, we were unsuccessful in that instance. But when there are issues locating people who really need care, we will do our best as we have the resources to locate those clients. So the same public health codes and laws that allow us to get information from labs and healthcare providers applies here for chlamydia and gonorrhea surveillance data, and they are reported by the STD 23 as well. Just going to give you an overview. You'll note here that for our data sources for chlamydia and gonorrhea, we do not typically have the interstate communications. On occasion, we will get a request from another state to locate a person with gonorrhea or chlamydia, but usually it's because they have another infection such as syphilis or HIV. So we don't typically get those types of notifications, so they're not included here. A colleague, I had a conversation recently with a colleague in informatics who reminded me that ELR is not a thing, it's a process. So you'll see I changed my diagram slightly to represent that labs are providing information in such a way through this electronic reporting process that the information can be input electronically into the Connecticut Electronic Diseases Surveillance System. So the information in which we call that CTEDs. So those data are reviewed by our program staff in order to determine if the laboratory results are complete and if treatment has been reported. So in addition to those data being electronically submitted to the Centers for Disease Control and Prevention, we evaluate, we basically look at what treatment for gonorrhea has been reported to ensure that it's correct. So in the case of gonorrhea, if the treatment was incorrect, we work to send a letter to the healthcare provider notifying them of the proper treatment guidelines for gonorrhea. And we basically encourage them to have that person come back in for proper treatment. So let's look at what the data tell us about chlamydia and gonorrhea in Connecticut and in the nation. So the CDC estimates that 20% of the US population in 2018 had an STI on any given day. For this analysis, CDC included chlamydia, gonorrhea, Hep C, herpes type 2, HIV, human papillomavirus, syphilis, and trichomoniasis. So for STIs, chlamydia, trich, HSV2, and HPV accounted for 93% of all new STIs in 2018. So it'll be very interesting to see what this infographic and what the data will tell us post 2020. So this CDC infographic shows us the national estimated prevalence of chlamydia and gonorrhea alongside the estimated number of new cases or the incidence for those conditions. So, of course, the other conditions look familiar to you. There are other sexually transmitted infections of great concern. And although chlamydia and gonorrhea incidence is lower than that of some of the other infections, these conditions are indicators of unprotected sexual activity. And as such, understanding their distribution in the population informs STI prevention and control activities. So here I have displayed for you the rates of reported cases of chlamydia. You'll see here that I have the United States, and this is the rate per 100,000. So I just want to give you an idea of what's going on in our region. I don't know about you, but I was pretty surprised that Rhode Island had the highest rate of chlamydia per 100,000 persons. So this graph shows the increase of chlamydia in Connecticut, that it follows basically the national trend. Not really sure what the dip in 2017 is about, but it might have had something to do with our migration from STD MIS into our previous database system into CTEDS. So this graph shows the upward trend in the number of chlamydia cases from 2000 to 2020 in Connecticut. So you see this dip in the number of reported cases. And we think that this may be due to the COVID-19 pandemic, due to the lockdowns. And from January, we do know that from January to April of 2020, many of the publicly funded STD clinics were either closed or on limited operations. And we also know that the community health centers experienced low patient volume due to social distancing requirements. They couldn't see as many clients as they normally did. So the frequency of reported chlamydia infections in Connecticut continues to be higher in females than in males. When we look at the frequency of chlamydia by age groups, we can see that in our state, as with the nation as a whole, chlamydia disproportionately affects 15 to 24-year-olds. When we look at chlamydia by race ethnicity, we see that the numbers are larger in persons who are classified as non-Hispanic white from 2017 to 2019. However, it's important to point out that the interpretation of these results has a caveat. 47% of the race ethnicity data were missing during this time period. Okay, so now let's take a look at gonorrhea. So Connecticut ranked 40th in rates of reported gonorrhea by state, across the 50 states. So we see that in New England, once again, the rates of reported cases were highest in Rhode Island, with Connecticut coming in a close second. Here are the rates of gonorrhea for Connecticut and the nation during 2000 to 2019. And I want you to note the upward trend starting in around 2015. And you can observe that there's some jumps in 2008, 2002, and 2013. So I'm just going to put it out there, and we might have it in the discussion and question portion. If this looks familiar to anyone, if you can think of another disease where we saw the same thing going on. Okay. Now, yes, I heard somebody say syphilis. That's right. Was that Robin? I think Robin pointed out the 2015 thing for syphilis during last week's session. So, you know, gonorrhea is terribly interesting because I think that many of us think about gonorrhea and chlamydia as, you know, being sibling infections. That, you know, if you see clients, they might have one or the other, but a lot of clients have both, right? And even the previous treatment guidelines kind of, you know, made you just think shorthand. Okay, I'm just gonna treat them for both, right? So it's super interesting to me that we can see this crossover in 2013. Where the reported cases of gonorrhea became higher in males than in females. So what happened? Well, the same phenomenon was observed for the rest of the United States. So CDC posits that this may be the result of increased transmission, increased extragenital screening among men who have sex with men, or a combination of both. So the STD surveillance network, which was a Sentinel surveillance project, suggested that the rates of gonorrhea among men who have sex with men, so this line here, is 42 times that of the estimated rate among men who have sex with women only. And you'll see here that the random sample this was done in sites including Baltimore, Philadelphia, New York, Washington State, San Francisco, and California minus San Francisco. So here we see that during 2015 to 2019, 15 to 24-year-olds represented 40 to 43% of all reported gonorrhea cases in Connecticut residents. And so you can see when we look at the case rates, we can see that if we combine these two groups, yeah, that's the leading, that is the, that the cases are highest in these two age groups. And of course, we see here in the 25 to 29-year-olds as well, but combined, these account for many of the gonorrhea cases that we saw between 2017 and 2019. When we look at gonorrhea by race and ethnicity, again, there's a caveat to this because from 2015 to 2019, 50% of race ethnicity data were missing for those years. But you can see that while chlamydia appears to be more frequent in persons who are classified as non-Hispanic white, gonorrhea appears to be more frequent in people who are non-Hispanic, Black, or African American. Okay. So now I'm showing you the super complex slide. and you're thinking to yourself, Ava's supposed to be talking about data. Why the heck is she showing me something about, minimum inhibitory concentrations? I'm showing you this because I want you to have a clear picture in your mind to set you up for Dr. Wangoon's talk on why the treatment guidelines have changed, and why it's important for clinicians to continue to keep up to date with the latest treatment guidelines, because we are fighting antimicrobial resistance. For whatever reason, Neisseria gonorrhea it mutates frequently. And so it becomes resistant to many medications. What's not shown here is there's something like 35% of there's 35% of samples that are resistant to fluoroquinolone. So that's why that medication is completely off, has been completely removed as a recommendation for treatment of gonorrhea. So this slide is showing you the MIC, or the minimum inhibitory concentration. Okay, so the MIC is the lowest concentration of an antimicrobial drug that will inhibit bacterial growth after that drug is incubated with the microorganism overnight. So basically, a lower MIC value means that less of the drug is needed to stop bacterial growth. So this image is from the CDC Division of STD Prevention, and you can see here that compared to azithromycin, right, the pink, cefixime, which I always mispronounce, and ceftriaxone, you can see that that ceftriaxone still remains effective against gonorrhea in much smaller amounts than the other drugs. Okay. And I just threw this in here. This is one of the messaging points from CDC. Some of the messaging that they're trying to put out regarding this problem of antibiotic resistant gonorrhea. So the take-home messages for you: both chlamydia and gonorrhea are more prevalent in people who are aged 15 to 24 years old. For chlamydia, more females, cases are reported among more females than males. And that was the case with gonorrhea until 2013. Chlamydia, and I put the caveat asterisk here, seems to affect in Connecticut non-Hispanic whites more than non-Hispanic blacks or persons classified as Hispanic, whereas gonorrhea seems to be more prevalent in non-Hispanic, Black, or African Americans. For both chlamydia and gonorrhea, the treatment guidelines have been updated. I'm sure by now you are familiar with the December 2020 changes to gonorrhea treatment, which was premiered before the 2021 STD treatment guidelines were published. Okay, and then I just want to close with this. So this again is an infographic from CDC from their 2018 analysis. And they calculated that new sexually transmitted infections cost, the medical costs were $16 billion. Combined, the STIs in youth and women accounted for 51%, or $81.2 billion of these costs. Now, given what I've told you about chlamydia and gonorrhea and who they seem to affect the most, it kind of pinpoints us that targeting women and youth could have some very beneficial effects on reducing the medical costs and the burden of disease of sexually transmitted infections in our communities. So syphilis, chlamydia, and gonorrhea accounted for 1.1 billion, or roughly 7% of direct lifetime medical costs. And again, just to reiterate, if we can prevent transmission of these three conditions, we can reduce medical costs. And since we know that the other conditions listed here, you can see HBV, HSV2, and trichomoniasis, If we can reduce the transmission of chlamydia, gonorrhea, and syphilis, we can have an overall impact on the financial and human burden of these infectious diseases. Now, I'd like to ask you to please consider improving your reporting on race and ethnicity data, because we can give a better picture of what's going on with STIs in our state if we have this information. All of our populations are at risk for STIs, and to really reduce health disparities, we need to be able to tell more accurate stories about the populations that need more public health intervention and healthcare resources to reduce disease transmission. So thank you to all of you for what you do to detect, treat, and report STIs, and continuing to work together, we can help more people to avoid infection and enjoy better health. Thank you.
Thank you, Ava. That was great. I am so happy that you were able to present things in such a way that you really gave us a full picture of exactly what the epidemiology is and the surveillance and how that all impacts what we do. So thank you for such a comprehensive overview. I'm going to open it up right now for any questions. If anyone has a question, you could put it either in the chat, or if you want to unmute and ask your question. We have about 10 minutes to answer any questions you may have. So please go ahead. One comment that I just wanted to make, and I wanted to make sure that I put it in the chat a few minutes ago. The 2020 data, I just wanted to remind everyone, if you saw on the slides, the data is preliminary. It still has not been finalized by CDC. So just keep that, in the back of your mind that, when we do present our final 2020 data, those numbers might change a little bit. I just wanted to make sure that that was out there for everyone. Does anyone have any questions at all? Oh, wait, we have one here. What's the best way for clinics to report to the state? And this is from Rachel. Currently, we're filling out the form and mailing it in. Is there an electronic reporting? I will take that one. Right now, the electronic reporting mechanism is not implemented. We've been working on that and had been working on that before COVID, and unfortunately, because of COVID-19 and the impact that it had to all of our systems, we have not been able to implement that, but we hope to be able to get an electronic form in format or some type of electronic reporting implemented in the very near future, because I know that would be very helpful for clinicians. So right now, the reporting is done through the form that we use, which is the STD 23 form, and that should be faxed into our fax number rather than mailed. When it's mailed, sometimes there's delays, and we prefer that if possible, that you can fax the reports in. And I will just, the fax number, it changed about 2 years ago, but I just wanted to make sure that everyone knows the new fax number, which most people are faxing to, thankfully. That number is 860-730-8380. I'll put that in the chat. Oh, actually, I think Ava might have put that in. That fax number is the one that will go directly into an electronic bin, and we can pull the reports from there. So hopefully that answers your question, Rachel.
I had a quick question.
Sure.
Should have, and maybe that'll be better sound. I just wanted to see if, was there any difference in like sort of local data in Connecticut, or was that study done on gonorrhea showing that there was azithromycin resistance? Was that just kind of a national study? And
The data on MICs, that's national data.
Yeah, and if I can add, Ava, so that's part of a study that's been going on for, I think, 30 years now, monitoring the MICs and the antibiotic resistance profile of gonorrhea, understanding that gonorrhea is pretty, can be pretty tricky and has evolved antibiotic resistance to multiple drugs over the last decades. So yeah, so this is part of that kind of ongoing study, which has actually been really helpful and obviously very influential in treatment policy changes.
great, thank you.
Okay, and Robin has a question. It's in the chat. Where did the new charts about the national stats come from? Not
So
sure.
Robin, are you talking about the state rankings?
No, I'm talking about the national where they're now saying 26 millions, and the one that spelled out HPV, the bar chart that had HPV and all. Where does
Yeah. Yeah, those are all from this. There's a CDC thing called STIs at a glance, and
Okay.
in my slide notes that you will be getting, you will see the data sources for everything that I've referenced.
Great, thank you.
You're welcome.
Got it. We have a couple of minutes remaining until our next session. Any more questions? I heard someone. Anyone have something? No? Okay. Well, hearing none, I think what we can do, we are a couple of minutes ahead, but if Christina, if you're with us and you're ready to start, maybe we can just jump into your presentation. I thought I saw Christina on a little while ago.
Barla? Hi, Barla.
Do you have an extra computer for Barla?
Oh, yeah, there's a bunch in here.
Okay, great.
There's a mouse.
Hi, if you're not presenting, could you, or asking questions, can you please mute? Thank you. Christina Langer, I'm not sure if you're on yet, but
I
we're...
am on.
Oh, there you are.
Can you hear me?
Yes.
Okay, you can see me. Can you hear me?
Yes.
Okay, good.
Yes, yes. Okay, so I'm just going to take a really quick minute and introduce Christina Langer, who is joining us this morning from literally from the state lab. They're in her office. Christina, we're so happy you're joining us this morning to present an update and some updates from the state lab. So Christina is the supervisor of the virology, serology, and STD section at the Connecticut DPH laboratory. She's been there since 2004. She's had many years of experience performing and validating test assays at the state lab for the diagnoses of HIV, hepatitis C, syphilis, and more recently, other STDs. She has a bachelor's degree in biology from Central Connecticut State University and a master's in public health from UConn, which she received in 2009. So we're happy that Christina's joining us this morning. And Christina, did you have any slides that you want to share?
I do. Let me see if I can get those on.
There we go.
Are you seeing my slides right now?
Yep, we are.
Okay. 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 And you just see one slide now, right?
Yes, yep, you're in
Okay,
slide
perfect.
presentation. Awesome.
Perfect.
Take it away.
All right, so it's a little hard to tell from my side, but okay. Thank you, Linda, for having me. I'm excited to get to talk to the clinicians today about the work that we do at the State Public Health Lab. So again, my name is Christina. I'm currently the supervisor of the virology, serology, and STD sections. Recently, STDs, which is chlamydia and gonorrhea testing here, merged with the virology, serology side. Previously, it was under the supervision of Gary Budnick, who retired in spring of 2020. So now all of these sections is combined into one group. So our section provides testing for chlamydia and gonorrhea, syphilis, herpes, HIV, and hepatitis. Now that we're all combined into one section, the best phone number for you to reach us is the old virology number. It's the 920-6662. So if you have any questions about any of this testing or you're looking for results, that's the best way to reach us. So I just wanted to go over some of the current testing that we provided. A lot of you are familiar with this already in case anyone's new. So this is our clinical test requisition. Whenever you submit anything, a clinical test requisition needs to be accompanied with each specimen type that you send in. Please make sure you provide all the required patient information, select the appropriate test. You can do multiple tests for one type of specimen. If you're submitting a blood, you can, request all of the syphilis, HIV, hepatitis C testing. And then for chlamydia, gonorrhea testing, we prefer you fill out a separate test requisition for each specimen source. So if you're submitting a urine, fill out a requisition for that. And if you have vaginal rectal swab, submit a test requisition for that also. So the current testing that we provide at the lab, we provide a nucleic acid amplification test for chlamydia and gonorrhea. This is the Aptima Combo 2 assay. It's run on the Panther system. We've been providing this assay since, I think, 2018. The specimen sources that are acceptable for this assay are vaginal, throat, and rectal swabs. That are collected in the multi-test swab collection kits. Also, endocervical and male urethral swabs. There's a different collection kit for those, and urine. And I don't have this on my slide, but I wanted to point out that only the vaginal source is the only one that can be patient collected or clinician collected. Everything else, the throat, rectal, endocervical, male urethral swabs have to be clinician collected. The storage conditions for these are pretty generous. You can keep them at room temperature or refrigerated, and we need to test them within 30 days for urines and 60 days for chlamydia. 30 days for the swabs. I also wanted to add one more thing at this point. I don't have a slide prepared for this. Our colleagues, the lab is in discussion with Maryland State Public Health Laboratory to provide antimicrobial resistance testing for gonorrhea isolates and cultures. I don't have all the information prepared for you right now, but Maryland State Public Health Laboratory does offer nationwide to the public health laboratories a gradient strip method for antimicrobial susceptibility testing for gonorrhea. And the intention of that assay is for the identification and antimicrobial susceptibility determination of suspected or confirmed Neisseria gonorrhea clinical specimens or isolates in which treatment failure and/or antibiotic resistance is suspected. So I hope to provide you with more information and a little later on, and I'm hoping we can put this up on our State Public Health Laboratory website. So they do offer this testing, and it's just a matter of the state lab working with them to set up an account and get the collection devices. and getting the information out for you. So yeah, stay tuned for that, and we'll either send you out a letter, put it on our website so you have all that information. So I'm also going to talk about, in addition to chlamydia and gonorrhea, I'm going to focus a little bit about syphilis testing today because we do have some exciting changes coming up. The current testing that we provide at the state lab for syphilis testing right now, our screening assay that we use is the VDRL, and it's a non-treponemal assay for the detection of reagent and serum. The reactive results are tighter to an endpoint, and they're confirmed with a treponemal specific test. The specimen types that we use are serum, and we also provide VDRL testing on cerebrospinal fluids. And then I also have the storage conditions. When you collect the serum specimen, it needs to be stored at 2 to 8 degrees, and the specimen should be forwarded to the lab within 5 days. For syphilis testing, our confirmation assay that we use currently is the TPPA, the treponemal pallidum particle agglutination assay. And this is for the detection of treponema pallidum antibodies in human serum or plasma. This test is only validated for blood or serum, not for CSF. And the storage conditions for the CSF are also, the storage conditions for this assay for the serum is also the same as the VDRL. We do provide herpes testing at the state lab. We have a herpes simplex virus DNA assay. This is a loop-mediated amplification and detection. The specimen types for this are cutaneous or mucocutaneous lesion swabs submitted in viral transport media. For this assay, the specimens need to be stored at 2 to 8 degrees, and we need to receive them and test them within 7 days. The specimens cannot be frozen, so we really do need to get them probably within 6 days to be able to perform the testing within the correct amount of time. Currently, for many years, we've had a herpes simplex IgG antibody test. It's an enzyme immunoassay. The particular assay that we've had since I've been here, it doesn't differentiate between type 1 and type 2. So I kind of question the usefulness of this assay, but we do get requests that we've kept it on board for now. But we do have a different assay in the works, and I'll get to that later in the presentation. So additional testing that we provide in the serology STD sections, we do provide HIV and hepatitis testing. These are the assays that we have. I'm not going to go over to those in detail, but we have an HIV 1,2 antibody antigen EIA. We also have the HIV 1,2 antibody differentiation assay, which is called the Genius. It's from Biorad. We do have an HIV 1 RNA viral load assay, and if you are interested in that, it has to be performed on plasma samples only. So we can't use the serum samples that come in. A separate plasma sample would have to be drawn for that. We do hepatitis C EIA testing, and we also confirm that for current infections with a hepatitis C RNA viral load assay. In addition to that, we also do hepatitis B surface antibody and surface antigen. So this is just a list of our websites, everything I just discussed. For all the different assays that we provide can be found in the directory of clinical testing services. This is on our state website. If you go to the laboratory website, you can click on the directory of clinical testing services and look for each test by its specific name, and it'll give you all the information on what the acceptable specimen types are and how to submit it. And then also on our website under laboratory resources is the link for the collection supplies and test requisition forms. So this can also be found online. And the number here is available to call the support service section to get any of the collection supplies that you needed, either for the bloods or for the chlamydia gonorrhea collection tubes. So I just wanted to give you a little information about what happens at the laboratory. So when you submit the samples, they go to our sample receiving area. The samples are evaluated to make sure that we're getting the correct sample type for the test that's requested. The requisition is evaluated to make sure all the information is there. Then also the accessioning is done on the sample. There's data entry that goes into our laboratory information system. And then the samples are delivered to the correct laboratory sections for testing. Once everything's up in the testing laboratory, we also check the specimens. For chlamydia, gonorrhea, we're checking the tubes. Well, for all specimens, we check that the tube is properly labeled. The name that's on the specimen tube needs to match the name that's on the test requisition. If not, we can't do the testing. For the chlamydia, gonorrhea collection tubes, we also check the volume for the urines, make sure it's within the lines. We make sure we got the proper collection tube for the source that you're saying is on the test requisition. And then for serums, once we get bloods into the lab, the serums are centrifuged, they're aliquoted into transfer tubes, and they're frozen. So for any of the HIV, hepatitis, syphilis testing, we do aliquot out the serums and freeze them until testing is performed. And we also check the requisitions to make sure there's no errors or omissions. That happens down in the receiving area, and they put receiving codes onto the specimens, so we're aware of that. So some testing laboratory activities. We perform the testing. Everything gets reported. Everything gets reported into our LIS system. Results are checked for accuracy. We also check to make sure the QC for each test is. There are quality assurance reports that get sent out for if the test request or the sample or the test requisition has any inconsistencies or omissions, if the patient's name isn't on the test requisition or it doesn't match or the data collection is not there, you do receive that quality assurance report that says that the results are going to be held until this information is provided to the lab. Testing cannot be performed if the specimen itself is unlabeled. If there's no name on the tube, we can't test it. Also, if there's no specimen, if we just receive a requisition, or if the specimen is broken or leaking during transit, we're not going to be able to test it. And if it's the wrong collection kit for the sample type, we also can't test it in that case. At the laboratory, we do call out positive results for certain tests. So for our syphilis assay, if we have a syphilis VDRL that's reactive and a syphilis TPPA that's reactive, we call out those results to the submitter so you can get the result right away and not wait for the fax report to come. All positive HIV results are called out to the submitter. For chlamydia, gonorrhea, herpes, or hepatitis, the positive results don't get a phone call unless there's a quality assurance issue that needs to be resolved. So if the specimen's on hold and we do one of those things are positive, then we will call you and let you know that you have a positive result and this issue needs to be resolved so you can get your faxed report. So now I'm going to switch gears a little and talk a little bit more about syphilis serology. Some of this is probably a review from last week's presentation, but it's just some more background information to kind of get us all on the same page when I talk about the different syphilis testing algorithms. So the diagnosis of syphilis infection still relies on both clinical evaluation and one of two multi-test laboratory testing algorithms to indicate current or past infection with Treponema pallidum. So there's two types of serological syphilis tests. There's the treponemal assays, which detect antibodies to T. pallidum. Treponemal tests include either IgM, IgG, or total antibodies. Antibodies detected by the treponemal assay tests arise earlier than those detected by non-treponemal tests and typically are detectable for life even after successful treatment.
Christina, I can't hear you right now. Is everyone else having the same problem?
Yes.
Yes.
Okay, can you hear me now?
Perfect.
He's back.
Okay, I might have hit mute accidentally. So I don't know at which point that happened. I was going over the two types of syphilis tests, the treponemal and the non-treponemal.
Yeah, you just started talking about the non-treponemal when you went out.
Okay, all right. So I just wanted to point out for the non-treponemal assay test that they can provide an endpoint titer for all positive samples, and titers will decline after proper treatment over a period of months to years. So this diagram is going to look a little familiar from last week's presentation. It's just an overview of when the different antibodies are detected in serum. And it's just, I just wanted to point out that the treponemal IgM antibodies are detectable slightly earlier than the treponemal IgGs and the non-treponemal antibodies. And also that the treponemal IgG antibodies are usually detectable for life. And then with proper treatment or even without treatment, the non-treponemal IgM and IgG antibodies will decline over time. So the next set of slides, diagrams that I have are from the Association of Public Health Laboratories report. They have suggested reporting language for syphilis serology testing. This graph came out of those guidelines. Those are a good tool for trying to decipher the different syphilis testing algorithms and the results and what they mean. So these are the different tests that are available. The non-treponemal assays, the ones we're most familiar with, are the VDRL, which we provide at the state lab, and the RPR. And then the treponemal assays, there's the FDA ABS, the TPPA, which are the manual type assays. The TPPA is what we use at the state lab right now. And there's also the immunoassays, which have been around for a while now, and a lot of labs have been moving to that as their initial treponemal assay. So there's an EIA, a CIA, and also an MBIA, which is a microbead immunoassay. So this is what the traditional syphilis serology testing algorithm involves. It starts off with a non-treponemal assay, so either the RPR or VDRL. If that's reactive, then a treponemal assay should be performed. So we use the TPPA currently. And then if they're both reactive, that's consistent with past or current syphilis. And if they're non-reactive, if the TPPA is non-reactive, syphilis is usually unlikely. It's probably a biological false positive. And this is just a guideline that provides the different steps in the algorithm, and it provides a laboratory interpretation for each of these scenarios, and also what further action could be taken. So this is a good resource. It's available on the APHL website. And I've been using this as a guide for when we develop the testing that we're going to provide soon. In a minute. This is the reverse syphilis serology testing algorithm. So a lot of labs in the past 5-10 years have been moving towards this algorithm. So this starts off with a treponemal specific test, and it's usually one of those immunoassays. If that's reactive, then you also perform a non-treponemal test with a titer if it's positive. So the non-treponemal is still either the RPR or the VDRL. If that's reactive, then it's consistent with current or past syphilis. If the non-treponemal test is non-reactive, this algorithm recommends to perform a second treponemal specific test. In a lot of cases, it's usually the TPPA. So if that's reactive, it's the TPPA, the second treponemal test is reactive. It's consistent with past or current infection. If it's non-reactive, then it's inconclusive at that point for syphilis. And this is the chart again that goes through the different steps, the different assays, and what the laboratory interpretation is for each scenario and the further action. So advantages of the reverse syphilis test algorithm. So the advantages of screening with a treponemal total antibody immunoassay, so it includes both IgM and IgG antibodies. It's specific to syphilis. The non-treponemal assays are relatively non-specific. There's a variety of other reasons why you can have non-treponemal antibodies. This assay can be more sensitive than the non-treponemal assay for detecting primary and latent syphilis. Also, this type of assay, the treponemal immunoassay, is available on automated instruments, so it's less labor intensive, it saves time, and there's potential for a quicker turnaround time for the results. So the changes we have coming to the STD testing services, we have purchased and we're going to implement a new automated instrument. It's the Biorad Bioplex 2200 system. The assays that we're going to have available on the system include the syphilis total and RPR assay, the Bioplex 2200 HIV antigen antibody assay, and also the HSV1 and HSV2 IgG assay. So it's just a picture of the Bioplex 2200 system. It's a fully automated random access multi-testing platform for clinical diagnostic assays. The syphilis total and RPR assay. It's a multiplex flow immunoassay utilizing a set of coded magnetic beads intended for the qualitative detection of total antibodies to treponemal pallidum and the qualitative detection and or titer determination of non-treponemal reagent antibodies in human serum or plasma. It is a dual assay, so it simultaneously can detect and differentiate the antibodies to T pallidum and also the antibodies to reagent produced during a syphilis infection. And we're able to perform titers on this instrument. We can get an RPR titer of up to 1 to 2048. So there are some limitations and considerations to moving to this syphilis total RPR assay on the Bioplex. The validated sample types include serum and plasma. So the Connecticut Public Health Lab is going to have to keep the syphilis VDRL assay for testing cerebrospinal fluid samples. Also, the performance of the Bioplex 2200 syphilis total RPR assay has not been established on neonates or individuals younger than 7 years of age. So in these circumstances, we are also going to need to keep the syphilis VDRL assay for testing infants. And finally, it's not recommended to compare the Bioplex RPR assay endpoint titers to those generated by manual methods such as the manual test. Since the manual tests are highly subjective, and there's a higher discrepancy that would be observed for a cutoff borderline weak positive samples. So what this means is when you're assessing the response to syphilis treatment, it's recommended that you use the same test methodology when comparing those titers. So if you use an automated instrument for your RPR titer, you should continue to use the same assay. You don't want to compare the automated RPR to the manual RPR, and it's best not to compare those two, and you don't want to compare the RPR to a VDRL when you're looking to determine if there's an effective response to treatment. So this is our anticipated reverse syphilis test algorithm at the Connecticut Public Health Lab. This is a work in progress. So this is what my intentions are. It would be to offer a syphilis antibody assay with a reflex to an RPR. And this would be for serum plasma only, not for spinal fluid. So we would perform the T pallidum and a total antibody screen. If that is non-reactive, there's no evidence of syphilis. If it's reactive or equivocal, you would also get the RPR results with a titer. And if that's reactive, then treponemal and non-treponemal antibodies are detected, and that's consistent with current or past infection. If that RPR is non-reactive, then like in that recommended algorithm, we would then do a second treponemal specific test, which is going to be the TPPA. If the TPPA is reactive, then treponemal antibodies are detected. That's consistent with past or current syphilis. If it's non-reactive, then the treponemal antibodies are not confirmed. It's inconclusive for syphilis. There's a potential for early syphilis, or it's possible that it's a false positive. So if you do have a high suspicion of syphilis, you can redraw and retest in a couple weeks. In addition to the syphilis assay, we are going to bring aboard a new HIV and HSV test on that instrument. The HIV antigen antibody assay is going to replace what we currently use for HIV screening, which was the Bio-Rad genetic system HIV combo antigen antibody EIA. So for this, we're still going to follow the recommended HIV testing algorithm. This new HIV assay is going to be your screening assay. It reports out individual HIV analytes. So for the screening assay, we can determine if it's HIV-1 antibody, HIV-2 antibody, and if there is HIV-1 P24 antigen present. We still are going to be required to perform the supplemental testing, which is that Genius assay. We also are going to bring on board the HSV-1 and HSV-2 IgG assay, and this is going to replace the current assay that we offer. So this new assay provides qualitative detection and differentiation of IgG antibodies to HSV-1 and HSV-2. So we'll give you a result for HSV-1 and R2. It does differentiate. So some of the next steps that we have to take to implement and provide the testing on the Bioplex involves installation of the Bioplex 2200. So the instrument is expected to show up next week, so very exciting. And then an engineer will be installing it. And then the next step is training the staff on the instrument and validation of the assays on the instrument. That happens, we also have to create and write up the standard operating procedures that need to get approved by management and the QA department. For our LIMS system, we need to create new A codes, and those have to be tested out in the system before we can move forward with that. The test requisition needs to be updated. The directory of clinical testing services, so on our website, we need to write up a new descriptions for each assay, and the website needs to be updated. So when all of this is finally done and tested and approved, then we can start providing these new testing services. Right now, I anticipate all of this taking, probably 3 to 4 months. So, I'm going to try to keep the lab, on task with that and get it available as soon as possible. So I just wanted to point out one more thing. For these new assays, the storage requirements don't change very much for the blood specimens than what you're already used to. For all the syphilis, HIV, and HSV assay, you're going to be collected blood. The serum specimen can be stored at 2 to 8 degrees for up to 7 days. So you still have a good window to get that blood sent to the state public lab for testing. That wraps up my presentation for now. I am available for any questions or comments or concerns that you have.
Thank you, Christina. That was awesome. We do have a question that was asked a little bit earlier, and I will ask it now. Robin wants to know if the state lab will be offering trichomonas testing at any point.
I did not mention that. We currently, no, I meant to. we currently don't have a trichomoniasis assay. There is a trick assay available on the Panther. That's the instrument that we use for chlamydia, gonorrhea. It would be easy for the lab to implement that. The holdup, as Linda knows right now, is really the cost. Using the assay available on the Panther, it's a NAT assay for trichomoniasis. It's easy to implement. We would use the same specimen collection device that you use for chlamydia, gonorrhea, so there wouldn't be an additional specimen collection that you would need to do. But it hasn't been offered up so far at this point. It's just a cost factor. There's a limited amount of dollars that are available for STD testing, and it's really just a determination of the STD program of best way to spend money. So I don't know if Linda, you want to comment any more on that?
Yeah, actually, we are looking at some possibilities for the testing. It's not entirely supported by our STD project officers because it's not a reportable disease, so it's not a priority. And so it is something that we are going to be looking into a little bit further, because I know that question has come up quite often recently. So we are going to be looking at that a little bit more closely to see if there's opportunities for us to obtain some funding. The thing that we want to make sure of is that, if we start offering it, that it's something that we'll be able to sustain. So that's really the question. Sometimes we do have some funding that comes in, and it's not something that's always available on a consistent basis. So we're going to be looking at it, and we'll keep you updated if there are any changes. So we do have some questions. Let's see, and we have another presentation at 9:15. We were going to take a break in between, and I don't know, we'll get through a few questions, and if we aren't able to get through all of them, we'll certainly follow up and provide some answers. Maybe we'll just have a Q&A document put together so that everybody has them, so that we stay on time. So Una asks, good for 7 days for syphilis, not the 5 that is now? That's a question.
Yeah, correct. Yep. So when we do offer the new syphilis test on that new instrument, yes. For both syphilis, HIV, and HSV, the blood is good stored at a refrigerated temperature for up to 7 days. So we do need to get it at the lab within 7 days, correct?
Okay. All right, great. Another question with regard to Josh is asking whether or not there's electronic reporting and requisitions from Practice Fusion. Not sure if you're familiar with that.
No, I'm going to say not at this point. We are going to be implementing a new laboratory information system in the near future. I don't know timeline is for that. That will probably also include electronic test ordering and result reporting. That's all under development. Right now, we are just in the process of reviewing vendors that submitted proposals to the lab. So we're not quite there yet. There'll be more information coming out when we do move to our new LIMS system, but it's still kind of in the beginning stages right now. So yeah, at some point we hope to offer electronic ordering and reporting. It's not there yet. I don't have any information for you at this point.
Okay, all right. And the other, we have a bunch of them in here in the chat. I think we'll just take one that I think is pretty common. And this was, do we accept both clinician collected and patient collected swabs for GC and CT NAT? If so, for which sites? Genital, extragenital?
Only, so I didn't have it on the slide, but I did mention it briefly. So only vaginal swabs can be clinician or patient collected. Everything else does need to be clinician collected. So rectal, throat, endocervical, urethral swabs all do need to be clinician collected.
And I think we could probably talk about that quite a bit, and maybe that could be a whole nother half hour or more session just to have that discussion. So I think we're gonna leave it at that. We do have a bunch of other questions, but I do want to give people a break before our next session. So we're going to break for let's see. I'll give you a 10-minute break till 9:20. Just want to thank Christina again for her presentation and for joining us this morning. And we'll definitely answer the rest of the questions that are in the chat. We might have some additional information pertaining to some of the testing with Dr. Wangu's presentation. So take a break, go get a cup of joe, and we'll see you back at 9:20. 9:20. We have a lot to cover for the next couple of hours. So I am so happy to have Dr. Zun Wangu join us this morning. Dr. Wangu serves as the clinical faculty at the Rattel STD HIV Prevention Training Center at the Massachusetts Department of Public Health. She is also an assistant professor of pediatrics at UMass Chan Medical School and attending physician in pediatric infectious diseases and immunology at the UMass Memorial Children's Medical Center. Dr. Wangu received her BS in biology and art history from Tufts University, her MD from the David Geffen School of Medicine at UCLA, and she completed her pediatric internship and residency at the Children's Hospital of Pittsburgh. She is board certified in pediatrics and infectious diseases and is a fellow of the American Academy of Pediatrics. And I'd like to thank Dr. Wangu for joining us. If you'd like to share your screen, I know you have a lot to cover this morning, so we can get started.
Sounds good. Thank you, Linda. Good morning, everyone. So let me just
Good morning.
My slides. All right, can everyone see?
Yes.
Great. All right, so yes, as Linda said, we have a lot to cover. This is going to be a whirlwind tour of GC, chlamydia, and some other STIs today. So I don't have anything to disclose. So this is going to be in a countdown format and it's going to be case-based. So I hope to make it interactive for everybody so that we can all stay awake, including me. It's early in the morning. So the first topic is going to be gonococcal resistance and changes in therapy. So our first case is going to be an 18-year-old individual with male anatomy who has sex with other individuals with male anatomy. I'm going to use this acronym, which was previously, stood for men who have sex with men, but I don't think that is a specific enough terminology. So I'm still going to use the acronym, but this is why I explained what I mean when I say MSM. So he's coming in for a physical and his only complaint is that he has some neck pain. So his last sexual exposure was a week ago. He has insertive and receptive oral and anal sex. And the only time he uses condoms is with anal sex, and that's 100% of the time. He had chlamydia a year ago that was treated. And he has allergies to penicillin and cefadroxil, one of the cephalosporins. He recalls a very severe rash when he was a child. No medications, no substance use. And on your exam, you only note some tender anterior cervical nodes. So what tests do people want to perform just based on that information? And you can either shout it out, put it in the chat, whatever you'd like to do. So do you want to do some NAT for gonorrhea and chlamydia at the throat and genital sites? Would you like to culture for gonorrhea at the throat and genital sites, or just focus on the urine NATs for both? And in my questions, there could be more than one right answer. So this is not sort of your usual prototypical multiple choice. So what do people think? 3-site testing using NATs, throat NAT. Great, what else? KA, so the throat and genital. And Jason, do you want to unmute yourself and say why you want to do 3-site testing? Because our patient did say he uses condoms for anal intercourse, but did you have other concerns, or has this come up for you in seeing patients?
Yeah, I mean, I guess sometimes I just do it anyway. Even though people say they are using condoms, sometimes, you know, it's not always consistent use. And then, you know, with any person who has male anatomy who's having sex with someone else who has male anatomy, I feel like 3-site testing is usually recommended periodically. I mean, obviously there are some cases where people are very much know that they're not at risk, but yeah.
Yeah, great point. So it's definitely worth a discussion with the patient to voice your concerns. Excellent. So this is his clinical course of your patient. This is based on a patient from one of our colleagues at the New York Prevention Training Center. So let's look at just visit 1, 2, 3, 4, 5, kind of left to right. So visit 1, you decide to do actually 3-site testing, but the only thing that comes back positive is the oropharyngeal GC NAT. So we're going to focus on his throat as the site of his infection. So that comes back positive at the first visit. You call him back and say, you know, your test was positive. Let's go ahead and treat you. Now, gentamicin and azithromycin was chosen for this patient in particular because of his history of allergy. With some additional questions for him, it was thought that this was a more severe allergy on the spectrum. And so he got gentamicin and azithromycin. However, as I'll talk about in a little bit, pharyngeal gonorrhea is especially difficult to treat. And so with that concern, a culture was also done at the follow-up visit, just in case of treatment failure, in case we needed to know susceptibilities. He comes back about 2 weeks later for a test of cure. Unfortunately, it's still positive. So then he's called back after that positive result to get more data. By this time, the initial culture comes back, susceptibilities were sent, and luckily the organism is susceptible to ciprofloxacin. When he comes in at this visit, both the culture and the NAT are still positive. Looks like the gent and azithro didn't work. So that's why he gets the Cipro. And then in the end, the ciprofloxacin was effective in treating his pharyngeal gonorrhea. When he comes back for his test of cure, both NAT and culture were negative. It's a little bit of a difficult clinical course. So what were we doing in 2015 for gonorrhea treatment? Let's sort of backtrack and review what changes have occurred. So we were doing 250 of ceftriaxone plus azithro, regardless of the chlamydia test result, in order to get around the issue of gonococcal resistance. And at that time, previous to 2015, doxycycline had been listed as an alternative to azithromycin. But in 2015, the update was that there was increasing tetracycline resistance in isolates of gonorrhea in the US. And so that's why doxycycline was demoted. So why have we changed our recommendations in the most recent iteration of the guidelines? This is why. So basically, these are the percentage of gonococcal isolates with elevated minimum inhibitory concentrations to various antibiotics. and that's called MIC. So what does an MIC mean? Basically, if MICs are increasing over time, that means you need more of the antibiotic to inhibit organism growth, which means the antibiotic is becoming less effective over time, and you're concerned about increasing resistance over time. So if we focus on that concept, azithromycin, it's not looking so great for azithro over the last couple of years, especially since the last iteration of the guidelines. So the percentage of gonococcal isolates with increasing MICs is going up, particularly for azithromycin. Cefixime and ceftriaxone, not so much. So that's one of the things that prompted the changes to now we're not going to do dual therapy. We're going to do single drugs, so treating gonorrhea with ceftriaxone at a higher dose, 500 milligrams, 1 gram if your patient is over 150 kilos. And then if your chlamydia testing is pending, or if you already know the patient has chlamydia, we add on doxycycline. If your patient is pregnant, and we don't want to give them a tetracycline because that can affect the baby adversely, you can give the patient azithromycin. So what prompted the change besides what I already talked about? So there's also concern for antimicrobial stewardship. Let us not use more antibiotics because they might be better, but it could potentially impact, other pathogens, commensal organisms that are part of the normal microbiome. So those are additional concerns. Also, why did the dose of ceftriaxone changes in pharmacokinetic and pharmacodynamic data regarding sort of what is the optimal dose to treat gonorrhea, and it's the 500 milligram dose or the 1 gram. And we talked about the azithromycin resistance as well. So if you have an anogenital infection, and let's say you don't have ceftriaxone available where you are, you can use cefixime, which is an oral 3rd generation cephalosporin, and then add the doxy if the chlamydia test is positive or is still pending. The issue with cefixime versus ceftriaxone, and this is an important one, is it is not equivalent in terms of bactericidal blood levels. So it's not going to be as effective at bacterial killing compared to ceftriaxone. And the other issue is there's not really that much treatment efficacy for pharyngeal gonorrhea. And we'll talk about why the pharynx is a little bit of a unique environment. What about if my patient is cephalosporin allergic? So this goes back to our case stem. So this has been studied in 2014. 2 regimens, gentamicin, a shot of gentamicin and azithro, or gemifloxacin, a fluoroquinolone and azithro. So both of those are quite effective at treating urogenital gonorrhea, but the trial was not powered for extragenital. There were very few cases involved. It was effective in those cases, but they couldn't really comment on the effectiveness in extragenital disease. And the 2 grams of azithro is hard on the stomach. I have patients who can't even take the 1 gram, let alone 2 grams. And so some of those patients still needed retreatment with standard dose ceftriaxone and azithro. So you could wonder, okay, has treatment for cephalosporin allergic patients, has that changed since this study was done, since the 2015 guidelines? And the answer is no, as long as it's not pharyngeal. So the CDC put out an MMWR in December of 2020, saying that gent and azithro is still an option if your patient is cephalosporin allergic and has gonorrhea, but only if they have urogenital or rectal disease. So what's up with the pharynx? What is the problem, and why didn't gent and azithro work for our patient? So we know that eradication is more difficult in the pharynx, but why exactly? There's a lot of research going on into this. So is there some different immunity going on in the tissue of the pharynx? Are there organisms that have more of a predilection to go there? Do we have, insufficient drug levels in the pharynx compared to urogenital sites? There are really no reliable alternative treatments. And this patient in the case stem is definitely not unique. So there have been many treatment failures reported with the gent-azithro combo for these patients with pharyngeal gonorrhea. I've had 2 myself. So if a patient's NAT is positive and they're in this very specific group of patients, so they have pharyngeal gonorrhea, but they have drug allergy and you can't use a preferred regimen, bring the patient back for culture. It's okay to defer treatment until you can do culture and susceptibilities. Oftentimes, patients with pharyngeal gonorrhea are either completely asymptomatic or their symptoms are incredibly mild. So as long as you have a conversation about your test was positive, please, protected sex or abstain until we can get more information and treat you. And then as you heard just at the last lecture, culture and susceptibilities for Connecticut are coming soon. So you hopefully soon will be able to have the capability of sending culture and susceptibilities. And in this case, the patient's organism was susceptible to ciprofloxacin, so that was an option. Guidelines for test of cure. So the prior recommendation was anyone who got an alternative regimen, whether it was urogenital, rectal, pharyngeal, come back in a week. Now it's pharyngeal. Everybody who has pharyngeal gonorrhea, regardless of regimen. So culture can be done as soon as 7 days. NAT, most people will pick that for test of cure typically, and you can do that at about 14 days. There have been reports if you do it sooner than 14 days, you may actually detect non-viable or dead organism, and the test will be mostly positive.
Zoe, do you want to take some questions that have come in?
Sure.
Okay, so there were a couple of questions and comments. 3-site testing using NATs. Don't know if that was a comment. That was from Jason. Jason, do you want to unmute yourself?
Oh,
Yeah, that was.
Yeah, that
Go
was
ahead.
for the question we asked on the case stem.
Oh, gotcha. I'm sorry. I stepped away for a second. I'm sorry. Okay.
Oh, no problem. Yeah, I think.
And we're okay.
Yeah, I think we're all caught up. Yes, I do have a chat open so I can see the poll questions.
Got it.
Yeah. Okay, so we're going to move on to chlamydia and azithromycin and doxycycline and what's going on and what should we do and also why. So let's move on to a different case. So a 19-year-old male comes into clinic. He tells you he has sort of mucus in his stool, occasional tenesmus, meaning he feels like he has to evacuate his bowels, even though his bowel is empty and nothing comes out. He's had 3 male partners in the last 12 months, and his last contact was 4 months prior. And he had unprotected exposures at the oral, rectal, and penile sites. So here's what you see on exam. To the left is the rectum. He has a tiny bit of discharge. All the way to the right, you can see sort of a greenish yellow discharge when you do a swab. And then the middle picture, for those of you who have seen or maybe even done anoscopy in the past, it's sort of like a pelvic exam, but in the rectum. And this is sometimes done for HIV positive men as screening for anal intraepithelial neoplasia. But you can see sort of irritation and also discharge in the rectum. So what tests do people want to perform on this patient? And you can pick any that appeal to you, or like I liked very much that you chose an answer that wasn't there on the prior one. Don't be shy. Okay, so we have a vote for GC chlamydia gnat in the urine, I think, or maybe Ellen, did you mean 3 sites or C?
B.
B?
That's what I do. B.
All right, people like B. Got it, thank you. Okay. Great. And another thing you can also do is anytime you have discharge, you can always send a gram stain and culture. I would say if the pharynx in the previous patient, if he did have discharge, you could definitely send a culture thinking, uh-oh, he's allergic, and uh-oh, he has pharyngeal. So anticipating potential problems down the road. So you could never be faulted for sending a GC culture as well. But NAT at the minimum is a great idea. And we'll talk about D and when we would consider D, or if we would. So great. So you're going to send the NAT testing. So what treatment would you like to give the patient the day of the visit? And some options are, I'm going to hold off and wait for test results. Do you want to give a shot of ceftriaxone while he's in your office? Or do you want to give ceftriaxone plus doxy? And the only difference between C and D is the duration of treatment, 7 days versus 21. So any thoughts on this one? I see a vote for C and a vote for D and another one for C. Great. So that's exactly what I was thinking you all might say. So not sure between C and D. So let's talk about that piece a little bit. So I will give you a test result. So your rectal chlamydia NAT comes back positive. Everything else is negative. So does that help you clarify your treatment? So do you want to continue the doxycycline for 21 days after all? Do you want to still limit it to 7 days? Or are you interested in some more LGV information? Three weeks because of the possible proctitis. Great. Yes, so there's a little bit of a concern that there's something going on beyond plain old chlamydia. So let's talk about that a little bit. So backing up, so what were the data for azithro versus doxycycline for chlamydia? And this is urogenital. So the recommendation was originally based on 12 randomized controlled trials where the efficacy was quite similar. The issue is that at that time when those studies were done, there were less sensitive tests being used compared to NAT. So that could have underestimated treatment failure. And as we know, doxy adherence is harder than azithromycin adherence because 7 days of something twice a day is always going to be harder than a one-time dose of something. So the question was raised about the efficacy of azithromycin. And this study helped to clarify a little bit the comparison. So this was a randomized controlled trial of azithro versus doxy. Again, this is only urogenital chlamydia by Dr. Geisler in 2015. So the setting was juvenile detention facilities. So this was a controlled environment where when patients are getting medications, ensuring that they're able to take their dose, they get their dose every day. So there were a few treatment failures in the azithromycin group. The efficacy was slightly higher for doxy, but really they couldn't establish non-inferiority of azithromycin, and both medications were pretty effective. So if you look at real-world application of these study results, although azithro had a few treatment failures, adherence was likely to be much greater with azithro compared to doxycycline. So still pretty equivalent. What about the rectum? So chlamydia transmission, the interesting thing is that even though we know so much about chlamydia, we don't know everything even now. And so the infectiousness and reservoir, we don't know everything about it. And transmission is largely due to people who are asymptomatic. So how can chlamydia be transmitted around the body? In many ways. So there's genitoanal, anal-oral, and there's even been shown, patients who do not endorse rectal intercourse, only oral intercourse, and they have negative negative on their history, there is GI transit to the large intestine and rectum. So chlamydia can actually travel from the oropharynx through the GI tract to the rectum and set up shop there. Who has rectal chlamydia in terms of women? So we always talk about, screening our patients who identify as MSM if they've had rectal exposure. But what about women? Does it help to ask about history of rectal intercourse or not? So the summary prevalence, women who are just coming in for routine care, it's about 6%. Among those who have vaginal chlamydia, it goes up to almost 70%. And studies have found that if you ask these women about rectal intercourse, you can still miss diagnoses. So why is that? Probably there's a little bit of, just by way of geography, with the vagina being close to the rectum, a woman can have vaginal chlamydia, and that's actually moving to the rectum. And again, the chlamydia is setting up shop in the rectum. So why are we concerned? Because when we treat vaginal chlamydia, doesn't that also treat rectal chlamydia? So isn't the azithro sort of taking care of that? No, it's not. And this is why there's a change from azithromycin to doxycycline for chlamydia treatment in the 2021 guidelines. Because in rectal disease, microcure is better with doxy. 2 major studies have shown this. One in 2019, this was in women, and the other one in 2021, this was in MSM. And so the microcure was significantly higher in doxycycline to the point where the Dombrowski trial was stopped early due to this interim analysis. So if you compare how patients did in terms of microcure between doxycycline and azithromycin, the authors pointed out that, azithromycin did pretty badly. And even if patients didn't complete the whole course of doxycycline, it was far superior to enact a microcure in this patient group. And so what do we still not know? Because there's always some more stuff we don't know. So what about beyond single dose azithro? Could you take azithromycin every day? Could you take it once a week for a couple of weeks? We don't know that yet. So maybe there are alternative regimens that might be helpful. We know that azithro fails, but we still don't know why. It's kind of like a similar question we're asking in the pharynx. Why doesn't it work down to the tissue or molecular level? We don't know yet. Is it that somehow the chlamydia is being suppressed but not killed? Drug levels are adequate in the rectum, and that has been measured, but maybe the host and the bacteria interact differently in the rectal environment compared to the genital tract. What's not likely to explain why azithro fails, azithro and doxy have similar mechanisms of action. There's really no chlamydia resistance to azithro. Like I said, the drug actually penetrates the rectal environment perfectly fine. And then you could say, and this is why I asked about LGV, could these patients have had LGV? And we know azithromycin is not effective against LGV. So maybe that's why it didn't work. But that was actually tested in the Dombrowski study, and it was very uncommon. So what about LGV, which is apparently, as I learned, chlamydia's wicked stepsister. So it's caused by different serovars to chlamydia. So it's sort of you can think of it as a subtype of chlamydia. It's really rare in the US, except for in MSM. So if you're exposed at the genital site, you usually will develop a small genital ulcer or papule. It's usually not super painful. Most people don't even notice it. It's very transient, and it usually resolves by the time of presentation. What's going to bring your patient in to see you is the painful inguinal adenopathy, which is usually unilateral. If you're exposed at the rectal site, you can develop proctocolitis, which now we're thinking, oh, maybe that's what our patient has. It can look just like inflammatory bowel disease in its presentation, or it can be completely asymptomatic. Some people don't have any symptoms at all. So how do you diagnose it? So since it's a serovar of chlamydia trachomatis, you can't tell whether someone has run-of-the-mill chlamydia or whether they have LGV just based on a NAT, because your NAT will be positive in both cases. You can do serologic testing for chlamydia trachomatis, same thing. So very few people do this, but if you do blood antibody, again, you can't differentiate. There are LGV specific antibodies that you can send, but you have to sort of interpret those with a grain of salt. They also take a little bit to come back. So you'll have to decide on treatment for your patient while waiting for that confirmatory testing. And then PCR-based genotyping, typically you have to send to CDC. It's not widely available. It takes a long time. So you're still going to have to treat your patient before your data come back. The treatment for LGV is doxy for 3 weeks. Some alternatives are erythromycin or azithromycin. That's really not optimal treatment. And you should do a test of cure if, let's say, your patient has a doxy allergy or something like that. So the key points for LGV. So always consider it if there's a compatible syndrome, particularly this case, proctitis in an MSM who also has a positive rectal chlamydia. Always do your other STI testing as you would do. And then if you feel like a case is compatible with LGV, you can send some of the other confirmatory testing, but you should probably treat presumptively as well if it's suspicious enough. Any questions on LGV before I move on, or chlamydia? Okay, so we're going to move on to some preventive things, which I don't think Smokey the Bear saw this coming, but that's okay. So how do we control STIs at the population level? So if we look at the basic reproductive rate of STIs, what are the variables that we can control? So transmissibility, how transmissible an organism is, we can't really do much with that. We can't really have control over number of sexual contacts, but what we can control is duration of infectiousness. And how do we impact the duration? It's by screening and treating patients promptly. And then we can have an impact on the basic reproductive rate and population. Screening is very important, particularly in the patient I just presented in the prior case, because it can pick up a lot of unidentified infections. So this is a study from 2011 that did three site testing on asymptomatic MSM. I believe this was an STD clinic. And so they wanted to look at if we had only screened the urine or urethral sites, how much gonorrhea and chlamydia would we have missed? And so you would have missed about 3/4 of the chlamydia and almost all of the gonorrhea. And again, this is asymptomatic MSM, which speaks to the importance of screening in asymptomatic individuals. Some changes for extragenital screening for 2021. So there was one change to chlamydia and gonorrhea screening in women. So we know we do routine screening yearly, all women who are sexually active under 25 years. But the new piece is that you can consider rectal and pharyngeal testing for women based on their history. So if they say I'm having unprotected oral sex or rectal sex, you can consider extragenital testing in those women through shared clinical decision-making, if you would like. And then gonorrhea and chlamydia in men, nothing really has changed here. So there's not enough evidence to recommend annual screening for MSW. And you can offer screening annually to MSM. So no big changes there, but there have been changes for women in extragenital screening. Self-collected STI testing, we heard a little bit about that. So the ones that are, the samples that are accepted at the state are the vaginal GC chlamydia NAT for patient collected. It's acceptable to many patient populations, and it can have equivalent or greater sensitivity than the samples we collect. Some patients I find are really comfortable collecting their own samples. They feel like they have more control in a very sensitive interaction or sensitive exam. And it can improve uptake of STI screening if patients feel like they have a little bit more control. So certainly offer it to your patients if they want to do it themselves, particularly for the state. We now know that vaginal GC chlamydia self-collected samples are accepted. Repeat testing after an STI, that's another important thing to impact that reproductive rate of STIs. So you want to screen people at risk, especially those who have had a prior STI, because we know from studies in sex workers in the US and STD clinic patients in the US that those who have had one STI are at significant risk to acquire another STI within the first year. So optimal rescreening should be done at 3 months after you diagnose and treat your patient. That's women with GC chlamydia or trick, and then men with GC or chlamydia. And there's no trick under men because there's not enough evidence to support test of reinfection for men when they have trichomonas. If patients have syphilis or HIV, you should test for those. The follow-up serologies for the two of those are a little bit different, but just sort of an FYI. And then of course, PrEP is a really important tool in high-risk individuals as well. So that can go along with your prevention and screening efforts. We're going to have an EPT panel after this, so I'm not going to talk about it in huge detail, but for those of you who are less familiar or not familiar with it, expedited partner therapy is basically treating the sex partners of your patient with an STI sight unseen. And this decreases the likelihood of reinfection in your patient. So this is what the CDC website looks like, and we're actually I'll show you how to get into the website and how to explore it a little bit at the beginning of the panel. So we'll come back to that. Is EPT effective? Yes. So this was a study in 2005 looking at standard versus expedited care. So yellow, I just treat my patient. Red, I treated my patient and gave meds in hand to my patient to give to their partner. This had a statistically significant impact on reinfection in the index patient for gonorrhea, and then we combined gonorrhea and chlamydia in particular. And it's been looked at in multiple trials and meta-analysis by now. So it shows reductions in chlamydia prevalence at follow-up and in gonorrhea, safe and effective, really no reports of significant adverse events for multiple programs across the US. And it's now permissible in 46 states. So when should you think about EPT? All partners in the past 60 days from when your patient was diagnosed, or if it's been over 60 days, just the most recent partner. Chlamydia EPT, that has of course changed from 2015. So instead of a single dose of azithro, we're now giving doxy. For gonorrhea EPT, if your state allows it, in Massachusetts, where I work, we're only allowed to dispense chlamydia EPT. In Connecticut, gonorrhea and chlamydia. So doxy plus ceftriaxone or the oral cephalosporin cefixime that I discussed before. And again, we can answer questions around EPT during the panel in more depth. Some changes in EPT, who can I give it to? So the main difference is that in 2015, the emphasis was that EPT could be dispensed to only heterosexual individuals. So why is that the case? So data are still limited for use of EPT in MSM. So what were some of the concerns about that? One was that MSM could be, the partners of your patient could be co-infected with other STIs. They could have HIV. So if I don't see the partners, I'm not evaluating them for other STIs or HIV. But this has been looked at in various populations, and that frequency in MSM, it varies based on the population studied. So the piece that has changed in the 2021 guidelines is that now you can officially, even though many of us were unofficially considering it anyway, EPT can be considered for MSM, again, using shared clinical decision-making if you talk about the risks versus benefits with your patients. Some patients have no problem telling you about their partners or getting their partners into care. Some people either don't know the identity of their partners, they might have anonymous partners, or they just don't want to tell you. And that's all of these things are important pieces of the conversation. But now that conversation is officially endorsed by CDC. And of course, everyone who is at risk based on their risk factors would benefit from other STI HIV screening, and of course, offering them PrEP. So PrEP, what's the general guidance? So it's indicated for those at high HIV risk. So if your patient uses intravenous drugs, or let's say they're a sex worker and can't use barrier protection consistently, or if they're an MSM who has, unprotected encounters or, anonymous high-risk encounters, whatever the risk factors might be, it's one tab once a day of HIV medication, Truvada or generic Truvada, or there's a new medication called Descovy. The patient should be HIV negative and have adequate renal function because the medication is metabolized renally. And they do need to come in for consistent follow-up for HIV and STI testing. And this is a tool that's significantly effective to decrease the risk of HIV acquisition. And it can just be used for periods of high risk. So it's not meant to take lifelong. It's based on the history that you obtain from your patient. So how do we prevent HIV? It's really twofold. So one piece is PrEP, but of course the other piece is antiretroviral treatment for our HIV infected people. So undetectable, if we can get our patients undetectable, it prevents transmission to partners as well. So that's the prevention piece. I'm going to move on to persistent urethritis and cervicitis. And this is an organism which I've heard many of you are interested in. So we'll get to that. So we have a 20-year-old MSW this time treated with doxycycline for urethritis 2 weeks prior. Initial testing for GC and chlamydia was negative, was compliant with treatment. He says he didn't have sex during the treatment. He still hasn't had sex because he still has these terrible symptoms. So how do we define recurrent and persistent urethritis? So the objective findings, and your patient should have all of those to kind of diagnose urethritis: some sort of discharge on exam. It can be mucoid and runny, or it can be frankly purulent. Usually a positive Luke esterase, and then more than 10 whites per high-powered field when you look at the urine. So if your patient still has this, you can retreat with the initial regimen. If the patient was non-compliant or they had sex again with their partner who wasn't treated. But in this case, the patient says that's not the case. He took all his medications and he did not have sex again. So you're a little bit concerned. So what other organisms might be causing this patient's symptoms? Mycoplasma genitalium. I knew you were going to say that. Excellent. M-gen, ureaplasma, M. hominis, trick. Great. Terrific. The only one I would add was potentially HSV. That can cause urethritis as well. Maybe the patient has lesions sort of inside the urethra. It's not visible to us. And you're right, this patient is heterosexual, so could potentially have trichomonas. We really don't see trick in MSM. So these are all excellent guesses. So a little bit about the epi. So for male urethritis, MGen is more common than GC, less common than chlamydia, but you can definitely have co-infections, and chlamydia co-infection in particular can definitely happen. Not clear whether it causes male infertility or sort of what the longer term significant impacts might be of MGen. And for women, for those who have cervicitis or PID, particularly if it's recurrent, it's found more commonly, but it's not clear that if you treat MGen as part of your treatment for a woman's cervicitis, that it prevents PID or endometritis in the long run, but it's certainly found more often than not in these conditions. So culture it's really slow, and most people don't have access to culture. And as we talked about in the last lecture, we don't have access to NAT right now, I believe. I think that was maybe Josh's question. And so, for example, it's available to be done on the Aptima platform. So for example, for my patients, we send it through Quest. They have a mycoplasma, ureaplasma PCR panel, again, done on the same platform as GC and chlamydia and NATs. And you can send it from different sample types for both women and men. So who should be tested for MGen? Men with recurrent non-gonococcal, non-chlamydial urethritis or persistent symptoms. Women with recurrent cervicitis, CDC, sort of their particular verbiage is consider among women with PID, but especially if you have a patient who keeps coming in with PID or recurrent cervicitis, I would definitely check. You can send a NAT if available. Resistance testing is really hard to find, but if you're available, if you have access to some of the smaller, some of the research labs across the US, you might have access to resistance testing. If someone is totally asymptomatic, you don't have to screen them. It's not clear whether if it's positive of treatment because it's gonna change their outcomes. And also you could have potential downsides from antimicrobial treatment in that scenario. So which medication should I use? So doxy and azithro have been compared, and clearly doxy is inferior to azithromycin. So there have been some more observational studies, maybe longer courses of azithromycin can yield higher cure rates than sort of a single dose of azithro, and could lead to decreased emergence of resistance. But as I just heard in a treatment guidelines update talk, macrolide resistance is increasing with Mycoplasma genitalium. So it ranges between 44 and 90% in the US. Some of the highest rates are, you can see in Seattle, up to 90% in MSM, 80% in Los Angeles clinic attendees. So it can vary. And if you don't have access to resistance testing, you'd be worried about, giving a macrolide if you don't have those data. What about fluoroquinolones? So moxifloxacin is the only one that is effective against MGen. But again, there has been some emergence of fluoroquinolone resistance in a few isolates. And so with all this concern for resistance, if we don't have testing, how should we treat our patients if their PCR turns out to be positive? So where we are now, most of us are going to be in this lower box. If we don't have resistance testing, what we do is doxy for a week, followed by moxifloxacin for a week. And so why are we using these two agents? So the resistance data that I just went over, the doxycycline specifically reduces the organism load and helps to clear the organism away. And then the moxifloxacin takes care of the rest. If you have access to resistance testing, then azithromycin is part of the regimen. Or if you have someone who, let's say, is allergic to fluoroquinolones or something like that, or if a patient is pregnant and has Mycoplasma genitalium and you're concerned about it, you're concerned about it being a major pathogen, an azithromycin-based regimen can be appropriate in that scenario. But primarily for everyone else, it's going to be doxy followed by moxifloxacin. Follow-up test of cure, you don't really need one if you're doing recommended treatment. Sex partners, it's not clear. So if you treat the partner, is your index patient going to have a lower risk of reinfection? We don't know that yet. So consider testing of a partner and treatment if positive. And then if you don't have access to testing at all, you can also consider just empirically treating the partner with the same regimen that you used for the patient. And same thing if you don't have resistance testing, which most of us don't. Moving on, I'm going to talk about recurrent bacterial vaginosis, which I now have a handful of patients in my adolescent medicine clinic who are really struggling with this. So I'm always looking for answers for them. So the classic scenario is this young woman who has 3 days of abnormal vaginal discharge and odor. She's had BV a million times. She's sick and tired of it. And she has the usual homogeneous vaginal discharge. When we put some potassium hydroxide on it, it has an amine odor and the pH is elevated. And so when you do your wet mount, you can see these vaginal epithelial cells that look like they've been sort of pressed in sand, and they're all covered up with tiny little Gardnerella, which is consistent with BV. So why is there recurrent disease? It's pretty common, but we don't know why. Are women getting reinfected? Are the good bacteria just not recolonizing? Are we not treating long enough? Or is there something else going on? Higher recurrence rates are definitely associated with shorter treatment, which is why we no longer recommend single dose metronidazole or sort of short course clindamycin as first line, because these women tend to come back. An important piece of BV that's a little bit unique is the formation of biofilms. And this is probably a factor as to why recurrent BV is a concern for so many women. So I like to explain biofilms to my patients as if it's sort of double sticky tape with bacteria stuck all over it. So a biofilm is basically a proteinaceous layer formed by the bacteria. You can see it kind of glowing orange in the upper two slides, and then the purple on the lower two slides. And so if you use antimicrobials that aren't active against biofilms, you can kill all the bacteria. But if you have just one little sticky guy on the double sticky tape, you're probably going to recur. And so addressing both pieces is very important. The other thing is BV, you have some odor, you have some discomfort, no big deal. Well, it actually is a big deal, because in 2016, at the International AIDS Conference, there were data presented showing that certain bacteria like P. bivia, Gardnerella, and a lack of the good, healthy lactobacilli can increase the risk of vaginal inflammation and actually HIV susceptibility and a risk of increased acquisition. So BV may actually be very important for acquisition of other serious STIs. So what can we do now for recurrent BV? So a couple of regimens are available. So suppression with Metrogel. What I tend to do is a course of oral metronidazole followed by intravaginal boric acid for 21 days. The boric acid is actually the piece that addresses the biofilm. So boric acid has been shown to be active in breaking down the biofilms. And then suppressive Metrogel for a couple of months. You don't want to use boric acid during pregnancy, though. Another regimen that they talk about in the guidelines is oral metronidazole with fluconazole, which can be administered monthly. So there are a couple of options. Alternatives to metronidazole, we don't use these that often, primarily because of the cost and they haven't been studied in pregnancy, and they're really not recommended for breastfeeding. So tinidazole, rather than a week, you can treat for 2 to 5 days. Secnidazole was approved in 2017, but for a single, and it's a single dose medication. But the cost is almost $300 for one dose, whereas 7 days of metronidazole is about $15. So I don't know many people who prescribe, honestly, either of these, but just know that they are out there and available. What I'm excited about is good bacteria. So a lot of my patients say, you know, what about yogurt douches, or how can I replenish the good balance in my vagina? First rule is to not use any fruit on the bottom. I do work in adolescent clinics, so sometimes you have to be kind of very clear. The other thing is that, yes, it's being studied. So powdered intravaginal lactobacillus, you can use it daily for a week, and then twice weekly after vaginal metronidazole. So this is a phase 2B trial. It's called Lactin-V. And what they found is there was a lower incidence of recurrence at 12 weeks compared to placebo. So this is one of the most promising treatments for recurrent BV, not ready for prime time yet, but keep an eye out and stay tuned. And hopefully this will be another good option for our patients soon who struggle with this. Partner management, treating a male partner really doesn't do anything. There's some data to show that female-female dyads actually share a lot of their vaginal microbiome. So you would think, oh, maybe in that case, if I treat the partner, maybe my patient will get better. There's not really a yay or nay in the treatment guidelines, but I've definitely tried this with some of my patients who have female partners. And then to sort of protect their microbiome and allow their microbiome to get replenished, you know, no douching, abstain from sex, or use a condom during and for a month after treatment, because maybe protecting them from their partner's microbiome will help them replenish their own. So BV is common, and stay tuned. Hopefully that Lactin-V will be ready for our patients sooner rather than later. I think we'll be, well, 5 minutes. Let's see what we can do. So trichomonas treatment has changed. Basically, I'm going to breeze through this pretty classic case of trichomonas in a 17-year-old woman. She only has this on her exam, so very frothy malodorous discharge, no other findings, and her pH is 7 or more basic. And you do your wet mount and you see these little, too bad this isn't a video, but you see the little trichomonads flagellating around, twitching around in your high-powered view. And so you diagnose her with trichomonas. So other testing options for trick, we talked about a little bit about this at the prior talk, how microscopy is really inferior to newer options like antigen testing or the NAT. TMA is a type of NAT. And so it uses the same technology as the Aptima platform. And you can see that the sensitivity is far superior to culture and to wet prep. And that's especially noticeable when it comes to whether you have vaginal symptoms or whether you're asymptomatic. The TMA still has superior sensitivity. So the patient got a dose of oral metronidazole. Her male partner was treated with metronidazole as well, but she still comes back and has trichomoniasis. So the next step, just for the sake of time, I'll just go through this a little more quickly. But the first time she got single dose metronidazole, and we have more data to show that that's inferior to a week of metronidazole. So this was an open label randomized controlled trial in 2018. And so the patients who got 7 days of metronidazole were less likely to be positive at test of cure than those who got one dose. And whether they had BV or not, there was no effect on the relative risk, no statistically significant effect. And importantly, the women, adherence was similar and side effects were very similar. So the current recommendation is 1 week of metronidazole for trichomonas, and that's going to be much more effective than the single dose. What about asymptomatic trich? So as I pointed out, the NAT has superior sensitivity in picking up disease, whether you're symptomatic or asymptomatic. Many patients can be in this group. And so the current recommendation is who needs screening? Asymptomatic HIV positive women, because trich increases the risk for PID, and trich can increase how much HIV virus they're shedding. Consider is the verbiage used, annual screening for high prevalence or high risk situations. So the language for trich screening, the point is that it's incredibly broad. And so, you can consider if your patient falls into any of these categories, particularly if you have a patient at a correctional facility, to go ahead and screen them. But this is as specific as it gets in the treatment guidelines right now in terms of screening. And the reason that it is quite broad is it's not clear if you have an asymptomatic infection and you're in one of these groups, is that going to reduce your risk of adverse outcomes? Is it going to change the infection burden in the community? It's not clear at this point, so we need more data. All right, we are almost done. So PID, metronidazole or not? So again, breezing through this case. So we have a 15-year-old female. She has nausea, abdominal pain. She blurts out she's not having sex. So you're a little suspicious that she 100% is. She's allergic to amoxicillin, and she has some signs and symptoms that worry you for pelvic inflammatory disease. She has lots of PMNs on her wet mouth, but you're not concerned for any findings that are supportive of BV. And you go ahead and send your nucleic acid amplification testing. So the question here, and I'll go through this so that we don't run out of time, is metronidazole or not? And I would say if she does not have IgE mediated, immediate type hypersensitivity to the antibiotics, I probably wouldn't go with a fluoroquinolone, mainly because if GC is involved, there's fluoroquinolone resistance. So the main question is metronidazole or not. So in the 2015 guidelines, metronidazole was an option, but it was not an absolute. So basically they said addition of metronidazole should be considered, but now we have data to show that it should be included. So this was a study from last year, women with acute PID, and the comparison groups were ceftriaxone plus doxy with or without metronidazole. So the main outcome was how are these women doing at 3 days? Also, they had endometrial sampling to look at anaerobic organisms, clinical cure, and then of course adherence and tolerability, like in the trich study. And so in the metronidazole group, they had fewer anaerobic organisms, they had less pelvic tenderness, they had less Mycoplasma genitalium in the cervix, which is interesting. And their adverse events and adherence were very similar. The median age in the two groups was 2 years apart. They were older. So conclusions, metronidazole absolutely should be given routinely for acute PID. And this is a major update for 2021. So we have gone through a whirlwind tour of lots of STIs. And so the last thing I'll just show you is a couple of resources to help you. So treatment guidelines are online. If anyone had the app, it's certainly currently under construction. So I've circled here, you can click here to find a mobile friendly solution in the interim until the app is updated and ready to go. CCN, some of you know this already because I recognize your names. You can go on stdccn.org and send us your warm line question. We can respond to you within 1 to 5 business days. And this is our team. So whenever you send in a question to CCN, one of us will help you. We have a nice mix of adult infectious disease, pediatric infectious disease, and OBGYN. And we're such a small group that we often put all of our heads together. So you can get many heads for the price of one. So thank you for your attention. I don't know if we have time for questions, but I can definitely be available to answer any of them offline.
Thank you, Zoon. Dr. Wengu, I really, really appreciate this. We actually, I think we only had a 5-minute break, and I think based on the amount of time we have left, I think we're going to skip the break and have time for maybe 5 minutes for questions, and then we'll dive right into the EPT panel discussion. And if anyone needs to take a bio break, just feel free to excuse yourself and come on back. So questions. Rachel asked, how are we getting boric acid for your patients?
Excellent question. So this was such a pain up to maybe 2-ish years ago. So our patients would basically go Breaking Bad and buy boric acid online from Amazon. They would buy empty capsules and they would fill it themselves. So that was one of their options. The other official option would be to get boric acid supplements or suppositories at a compounding pharmacy, but that was often really expensive. So one of my patients wanted to do that. And for 21 days of boric acid, it cost her, I think, between $100 and $200, which she absolutely could not afford. She was a young adolescent, didn't have that kind of cash for boric acid. So now you can actually find it in Walmart. I have had patients find it at CVS, Rite Aid. One of my patients told me that boric acid is actually blowing up on TikTok, so it's getting more attention. And one of my patients found a brand of boric acid at Ulta, which was very interesting. So you pick up some mascara, you get your boric acid. So it's much more available now than it used to be. I always have to review with my patients a couple things though. One, it's not FDA approved, so we have to have that conversation. And two, please do not eat it. You could die. That's an important conversation, especially with my adolescents who sometimes tune out when I'm talking to them. But I was really happy to see it's much more available than it used to be. And it's a lot cheaper. One of my patients said it was about maybe $15 or $20 for a 21-day course. I don't know if others have had luck getting it at other places, but that's how it's better now, I would say.
Okay, that looks like that was the only question that was in the chat. So I think if everybody is available that's participating in the panel discussion, I think we're going to dive right into that. Dr. Wengu, if you're okay and ready for that. Okay.
Sure.
All right. So just really quickly, today we're going to have our panel discussion is going to be facilitated by Dr. Lynn Sosa. We're going to be joined by Mitchell Namias, who is our clinical consultant for the Department of Public Health. He's a registered pharmacist for the past 5 years, and he worked in a community pharmacy since 2009. And also, we're going to be joined by Rayanne De Pasquale, who is a clinician at Planned Parenthood in their centralized follow-up office. And I think we're going to get started right away. And actually, Dr. Wengu is going to be starting us off here.
Yes.
Yeah, thanks, Linda. So yes, Dr. Wengu is going to kind of just do a quick overview, but we really wanted this to be kind of free flowing. And so people can feel free to ask questions in the chat and, other things where we're prepared to kind of try to address as many of the issues related to EPT as we can. So thanks, Zoon.
Great. So let me pull this up. So this is just kind of recap. What did we already just see during my lecture? So infection during follow-up, completing the EPT trial. So we know that it's impactful for gonorrhea and when you combine gonorrhea and chlamydia. again, effective. And we want to empirically treat all partners who the patient has had in fewer than in the past 60 days, or most recent partner if last contact was more than 60. This is the current EPT recommendation if you're going to give it for chlamydia and gonorrhea. And so we'll be happy to hear your questions about any details about how to do that. And then difference from 2015 to 2021 in terms of, not only limited to heterosexual partners, but also now discussing with your patients who identify as MSM in shared clinical decision-making. So just a couple of reminders. So I did promise you we would travel to the EPT site. So hopefully this will work. So here's the site. So there's an overview about expedited partner therapy, and you can put into any search engine, CDC. And so if you scroll down to the little US map, here's legal status. So let's click on that. And then if you scroll down, you can see the entire map and see where is EPT permissible, potentially allowable, and where is it prohibited. And I'm very happy to say that this time when I pulled up the map, it's prohibited in exactly 0 states, which is terrific. So let's go to Connecticut and see what it says. So you can do this for any state. So we see EPT is permissible in Connecticut. And here's sort of the details. So you can do EPT explicitly for chlamydia or gonorrhea. Under prescription requirements, this is really important. So prescription labels for drugs dispensed by a physician must bear the patient's full name. And you might be thinking, wait a second, isn't that the whole point of EPT, is that I don't know the patient's full name? So I think Rayanne has some good points about how she has dealt with this in her clinic. So we'll talk about that. And then, is EPT permissible? What are the other details? And the legend kind of tells you when you look up for each state, what you're going to find in terms of supporting, not supporting, is it permissible, allowable, etc. So anywhere that you work, you'll be able to find this. The last quick point that I want to go over is, great, so EPT works, but in which form? So just a reminder that the original studies were done with patient-delivered partner therapy. What does that mean? Meds in hand. So a lot of us do prescription-based EPT because we don't have access to medication in our clinic. Some of us do. But it's important to remember the efficacy of prescription-based EPT has never been studied. And there was one in particular in 2020, 32 clinical sites across a couple states in the US. Patients were given vouchers for azithromycin EPT because in 2020, EPT was officially with azithro. Only 41% of these vouchers were redeemed, and fewer people who are under 18 years of age redeemed them than over 18. So the point is, less than half of these prescriptions are filled even when medication is free. And I'm telling you this not to be a Debbie Downer, but whenever possible, EPT, we should give it as drug in hand. So if we can't do this right now, the seed that we just wanted to plant and stimulate this discussion was, how do we collaborate with our pharmacy colleagues and clinic and hospital leadership, whatever it might be, to move towards PDPT instead of prescription-based EPT, which we know just doesn't work as well. So with that, I'm going to stop sharing with that intro and open it up to the audience for any questions that you all have.
So I think we can kind of just to piggyback on your opener, Zoom. Rayanne, would you be willing to kind of share what your approach has been to EPT in your clinic?
Hey, sure. So I work for Planned Parenthood of Southern New England. So, and currently I'm in the centralized follow-up department, but I was seeing patients mostly in the Norwich location the past couple of years. So in our follow-up department, we manage all of the positive STDs, chlamydia, gonorrhea, trichomonas. And with our education to the patient, it's included to offer EPT to all patients that have a positive result, whether you're in the office with them and you give the positive result or if it's over the phone. Did I answer the question? Yeah. What else? Does anyone have any questions about that? Yeah.
Yeah, so I just put in the chat, people can chat their questions or they can raise their hand. So Rayanne, any challenges that you would like to share or things that you've gotten around? So for example, this issue of needing to at least know the patient's name.
Yeah, so I mean, that does have challenges. It takes time. Sometimes the patient that you're seeing doesn't know their partner's full name. We usually ask for a partner's full name, date of birth, and if they could check and see if they have any allergies. So sometimes that takes a phone call back from the patient, or we have a portal that we use, a patient portal. Sometimes they message us in the portal with their partner's full name, date of birth, any allergies. So we include that with calling in prescriptions, or if we see a patient in the office, we, of course, if we dispense the medicine, we put the partner's name on the bottle, date of birth. We have a form that says on there, if you have any allergies, to call Planned Parenthood, things like that, to give to the partner.
Great. So Mitch, any thoughts from your perspective as the pharmacist who might be getting a prescription that is meant for EPT?
Yeah, so I like how we highlighted the fact that we do need a name on the prescription. I like the way that Rayanne just outlined how she handles it, her practice, by requiring the name and date of birth at least, because if you do have to call in a prescription, those are at least the required elements of a prescription. There have been times in the past when I've been handed a blank prescription with no name, date of birth, and it was for EPT, and you could tell by the dosing of the medication. And it was like, technically, I can't fill this. So I'm glad that we covered the requirements for name and date of birth on there. As for how to get the prescription to the pharmacy, obviously, we prefer the meds in hand route to make sure that the partner patient gets treated ASAP. But if you do have to call in a prescription to a pharmacy, a lot of times there's challenges, because if you're using electronic prescribing, the patient won't pop up in the EMR. So you can always pick up the phone, leave a voicemail in the pharmacy, say, I'm calling in a prescription. Can you please double check the patient's allergy history, medication history, while calling in the prescription? You could also fax it in. I know pharmacies are super busy lately, so calling and actually speaking to a pharmacist or intern these days is very rare. So those are just my recommendations to try and, because you guys are busy too, so streamline the workflow, just leave a voicemail or do fax.
Thanks, Mitch. Would anybody like to share their experience with EPT or how they have operationalized it in their clinic?
I just had a quick question. I'm sorry for the pharmacist, Mitchell. It's good to meet you. So in terms of how this works, I'm assuming that if we're seeing a patient on their schedule, we know the name of the partner. Electronic prescribing wise, we just can't prescribe a medication on their chart. We would have to actually fax in a new prescription specifically for that patient, not on the chart of the other patient, right? Is that correct?
So that depends. There's ways around it. I know some clinic sites have like a dummy EPT patient profile that they'll register it in. I believe in previous discussions it was mentioned to put in the partner, the patient that you are seeing in the office, put in the details about the partner patient in their note to record that you are dispensing it. But I will also kick it over to Rayanne to see what she does there, but that's my perspective on it.
Hi, yeah. So our electronic health record, I don't think there's an option for us to send a script under one patient's record for their partner. We either call it in on the phone and leave a voicemail that it's EPT for the partner. We give meds in hand, or you could do a paper prescription. I haven't done that in a really long time. I don't even know if I have a script pad. It's probably in the safe at the office. Most of it is either by phone or meds in hand for EPT. But maybe I should bring that back to Planned Parenthood. Maybe there is a way through our EHR that we could have some sort of log of calling in EPT. I don't know the answer to that. Yeah.
So along those lines, in terms of kind of workaround, someone is asking about, okay, so we don't know the name of the partner. We still want to give EPT. Can we give a refill to the patient, right? Or I think the other method I've heard is kind of doubling the dose, right? So you're writing the prescription for the patient. So you write for extra medication that then they could give to their partner. So any thoughts from the panel on that?
So from a pharmacy perspective, I'm going to be the Debbie Downer. As much as we want to treat the partner patient, if you do send a prescription to the pharmacy and you knowingly put a refill on it and say this is for your partner and all that, and the pharmacy bills the person's insurance, that's technically insurance fraud if they're giving the medication out to someone else. So I do not recommend that. It is a barrier. It's not an easy or simple thing. Trying to ask the partner or trying to ask the patient for the partner information, but that is what is required in the Connecticut statutes, that you need the name of the partner on the prescription.
Any other thoughts from the panel on that?
I've definitely had colleagues who have done that, always a little bit nervously. But usually, if there's really no other option, they have, called and spoken with the pharmacist and said, this is what I'm thinking. This is why I'm thinking it. Is there any way we can make this work? And so I think the most important piece is always, always communication with the pharmacist, because they want to make sure, is this prescription correct? Are we overdosing this patient? What is it for? So I think, like Mitch was saying, just always reach out and discuss, how can we do this? And I've had so many lovely conversations with pharmacists who we've just figured out a way to get it done. But communication is the most important thing here.
Thanks, Zoon. So another question that's come up, so in Connecticut, as Zoon made clear, so EPT is specifically allowed by law for chlamydia and gonorrhea, which is good. But what about EPT for trichomonas? So I guess I would be interested in hearing about first kind of, do we have any evidence on the effectiveness of EPT for trichomonas? And then kind of what are the thoughts on EPT for trichomonas, which is not specifically addressed in the current statute? So Zoon, I don't know if you know, I think, since I have COVID brain, my recollection is that there is less data for trichomonas, but I believe there is some.
Yeah, exactly. It's just more data for GC and chlamydia. And so some states, I haven't checked lately individual states to see which ones can actually do EPT for trichomonas. But yeah, it's just the amount of data that we have. So technically, I mean, that's always hard, right? What is written legally? I don't want to be sued. I want to protect myself, but I want to make sure the patient is taken care of. So it's a similar thing in Massachusetts, where we are only covered for EPT for chlamydia, which is different from Connecticut. So I'll often get questions from OBGYN in particular. My patient has trich. I want to make sure that she doesn't get reinfected. She's pregnant. This could be a bad situation. But I don't think I've had anyone who was willing to do that, because if they prescribe EPT and something happens, they would not be covered.
Got it. So another question for you, Mitch. So so we have a prescription that has the name of the partner on it. Is there any issue with somebody other than that partner picking up that prescription?
Typically, no. So as long as they can verify the patient information, so name, date of birth, address, prescription can be released to anyone who verifies that information. That's just the standard practice across pharmacy. So your mileage may vary. I mean, obviously, if it's a controlled substance, they might get a little sticky, but that we're not talking about that here. But we have people pick up prescriptions all the time for someone else, as long as they can just verify that information.
So back to trick. So I don't know if Una, if you just want to unmute yourself and talk about your issue, because I think it's an important one to acknowledge. You know, so for example, if the patient has chlamydia or gonorrhea and trick, so we're going to do EPT for one but not the other.
Yeah, sure. It comes up quite a bit, and it's really hard to say, well, I can call in, you know, for your partner for the chlamydia treatment, but I can't call in for the trichomonas. So I know that we have called in for both the EPT for chlamydia and trick, or we, you know, really encourage the patient to get the partner to come in. So it, you know, it just makes it difficult because we do see a lot of, you know, co-infections with trick and gonorrhea or trick and chlamydia. So it's been awkward.
And that is a constraint with the current law that is in place. So, you know, working in state government, you know, we deal with legal and law all the time, and very seldom is there a law that specifically states what you can and can't do. A lot of times there's gray area. This particular law limits it to just chlamydia and gonorrhea, but it also gives you some leeway, because it says if you do prescribe EPT for the partner, you are not violating the standard of care. So that's one good thing on your side. However, the law is restrictive in that it's just limited to gonorrhea and chlamydia.
Yeah. Yeah. And I will say that it took us 3 tries to get to the law that we have there, but, you know, recognize that that type of law is not super flexible, right, as things change. I think so for other public health initiatives where we've instituted laws. So for example, recently changed our tuberculosis regs so they're consistent with CDC guidelines. This is another place where, and I think Kathy might want to weigh in on this because she's posted what the current CDC STD treatment guidelines say on this issue. You know, it's tricky because it looks like we don't really have a lot of evidence on the effectiveness of trick, of EPT specifically, but recognize that. And certainly when I was seeing patients, I experienced just a lot of reinfection when it comes to trick in particular. So you want to add there, Kathy?
Yeah, I think it's complex because what the law explicitly states is one thing, but it has not been explicitly prohibited by law not to do EPT for other diseases. And here, I mean, you know, if you broaden your thinking for other diseases of public health significance, let alone sexually transmitted diseases, there are many of us who are pediatricians who have written scabies prescriptions for other members of the family. There are many of us who have been involved, actually not many of us, thankfully, who have been involved in meningitis outbreaks, where we have written prescriptions for patients we do not specifically examine first and always obtain the perfect allergy history, right? So when we make the distinction and call it out and say gonorrhea and chlamydia explicitly legal, it didn't make explicitly illegal. Correct me if I'm wrong. The process by which you could do it for trick. So then to know whether or not a malpractice suit could ever even survive, you would need to know what standard of care is And one can argue that the CDC STI guidelines establish standard of care. In essence, what they are trying to do in this partner management section, remember every single syndrome within and every single disease within the STI guidelines has a section specific to how you should approach the management of sex partners. And this section for TRIC essentially boils it down to the evidence base is not perfect, but consider doing it. So carefully read that, make your choices and trade-offs clearly in collaborative decision-making with a patient who has been repeatedly infected. Many of us struggle with this, and if they're in a situation where they can't get their partner in for treatment, better is not the enemy of best. We live in a world of trade-offs. Zune, hopefully I was clear. Lynn?
Yes, I'm glad you put the verbiage in there too, because it is hard to make these decisions, and kind of like a lot of points that I focused on today, shared clinical decision-making plays a bigger role officially in the guidelines now than it used to. And so just knowing sort of what the verbiage is, what the legality is, will help you make those decisions. But yeah, it's not entirely black and white, and it can be hard.
Thank you both. So we have another question just in general about other strategies for getting partners treated. So I think we recognize that the best way is to get the partners in to be seen by a clinician, but that might not happen with that patient's clinician. So the question is, can folks be referred to the state supported STD clinics who've had a known exposure? And certainly the answer is yes. I would say that if that is the strategy, it's always best to to call the STD clinic, make sure that that person has the best paperwork, or that you're saying, yeah, I can verify that this person was a contact to XYZ. So that will help the folks in the STD clinic treat that person both appropriately and efficiently. All right. Any other questions?
I had one that I just put out there. It's a little tangential, or a little farther away from what we were talking about before, but I was kind of wondering if anyone knew how the CT Anonymous Partner Hotline works. I know there are some patients that just don't want to contact their partners for whatever reason, and I thought that might be a good resource. I'm not sure if I just didn't know how that exactly works, what information they collect, things like that. Maybe it's pretty self-explanatory, but.
So I'm not aware of a partner line. So are you referring to the DIS contacting people? I don't know. I think unless I missed something.
Yeah, I'll put the link in the chat. I don't know. I found this on the portal for CT government, and they have a partner services information section that has an anonymous line on it. I just don't know. I haven't used it myself, or like tried to get through or something to kind of test it out, but.
Got it. So I know we have some DIS on. Ava, are you still on? Or anybody from the DPH staff who want to talk about our services and what our priorities are?
So this is Linda. Actually, I think what Jason's referring to is just the fact that we do have a central line that people could call, which is the health department line, and talk to somebody about, a referral for partner services. And all of the services that we offer are entirely confidential. So that might be what you're referring to. And I'll have to open up the link that you shared. But I think we do have a couple of DIS, and I don't know, Ava, do you want to speak to this question, or I can just follow up? All right. So I think, actually, I see Kim is on. So Kim, would you be able to just chime in a little bit and just let everyone know about how our partner services work? You have to unmute yourself.
You may be talking about the Leave It to Us campaign that we had, because I know that was on our website.
Oh, yeah.
But, you know, as DIS, we do anonymous partner notification, whereas we talk to the patient who's infected and find out who their partners are, and we notify those people that they've been exposed to whatever infection it is and try and ensure that they get treated. But we do it anonymously, so we don't tell them who the original patient is when we do that. So I don't know if that's what you're talking about, or if you're talking about the link that you saw for Leave It to Us, where it explains kind of what we do. And I know that's on our website, so that's probably what Jason saw.
So Jason, I think the point here is that certainly, like, if someone thinks they were exposed, or if someone wants to learn more about that, then they can call us. I think tradition, and that was part of before the pandemic, we had a kind of campaign to just kind of let people know, like, if you get a call from the health department, this is why, right? And that this is legitimate, that we collect this information, but we're calling you to make sure that you are treated appropriately and to help you. And so it was really to kind of raise awareness about the fact that we do this, so that people might be more willing to talk to us when we actually get them on the phone, or if we text them or whatever. So that was really the goal of that. And certainly, so usually it's more about us reaching out. People can certainly reach out to us, and we can have that conversation, and certainly refer them to treatment if that's what they're looking for.
And this is Linda again. I'm just going to point out too, Zune actually posted a link for another option that's available for folks. And it's something that we refer people to. It's called Tell Your Partner. And that's actually an anonymous way of people sending texts to their partners anonymously to let them know that they have been exposed and to get tested. So that's something that we also offer to some of our clients who may not want to share their partner, but they do want to notify their partner. So it's available online, and there is the link to it in the chat. If you have any questions about that, you can reach out to any one of us, and we'll be able to help you with that. And we have 5 more minutes, and I just wanted to thank everybody for this discussion. I think we could have had a lot more time, and we tried to make this meeting short and sweet so that everyone could get the information they needed about the guidelines. But I know there's some other questions that might be out there, so we have about 4 more minutes. If anyone would like to put something in a chart, and also, the chat, or just open up your line and ask your question. You have 4 more minutes.
Sorry, just sliding this one last in there. So this was the number I sort of was using, and I'm guessing that you're saying I just wanted to repeat back what I kind of heard is that this is kind of like the main line for DIS services, and that they offer this service, but it's kind of like the main line, not like a specific hotline or some kind of special different service or something.
Yeah,
Okay.
no, this is actually the main STD control program main line directly to our section. And in our section is where all of the disease intervention specialists reside. And so we would be, conveying any messages about partners to the DIS. And, just to let you know, as Ava mentioned, routinely we do follow up on syphilis cases, but at this point, we don't have the capacity for gonorrhea or chlamydia. So if anybody has any other question, any burning question, please feel free to put it in the chat or open up your line. All right, well, let's see. There's a question. Rachel asked whether other clinicians have been seeing good compliance with the new treatment guidelines. And I'm thinking that's particularly in relation to chlamydia and the doxy. Yeah. Anybody want to comment on the compliance? Because I know that has been a concern. And I know Kathy or Zoom could actually speak to the compliance issue as well.
So the messaging has only just begun to go out to all clinicians. And I think just as clinicians are only human too, so all of us have to process this information on different timelines and really come to grapple with this issue of adherence being not as much of a concern as maybe previously thought. And then doing the pivot to doxy becomes easier once you process how much rectal infection actually is present, particularly among women, and the potential for auto-inoculation. So once that's processed, it's been fairly easy for groups to do the pivot. I think there's also, this has ripple effects through every arena where chlamydia is a concern. So for sexual assault guidelines or for prophylaxis guidelines or other concerns, people in the ER world are processing their algorithms and slowly shifting them. I think a larger question is, could we answer this using data? How many of us actually feel we have accurate information at the state level on each and every chlamydia case and what precisely it's treated with? I would venture a guess, knowing what I know of state surveillance systems, that much of chlamydia reporting boils down to individual clinicians doing very hard work, or clinical systems that have bottled how to scale up doing reporting using electronic clinical case reports. Some larger clinical systems have actually been able to do that. Those data will eventually come out, but it is too soon to tell considering these guidelines just came out in July. So I'll sum up by saying, I think that a lot of people are doing the pivot. I'm seeing this amongst my colleagues, but it will be slower than maybe one might hope or wish for. Let's see what the data show us in about a half year to a year after the advent of the guidelines. I don't know if others have comment.
Yeah, I think especially for, some of our younger adolescents where we worry about compliance to begin with. So for example, if we have especially a younger adolescent diagnosed with PID. I'm kind of thinking about a recent patient I had. I would call her, every 1 to 2 days to check in and see how she was doing with her medication. So sometimes it's based on the patient more than the clinician to just check in and make sure, so that if there are side effects, we can sort of cut people off at the pass. For example, oh, I didn't know I shouldn't take my doxy and then lie down right after and take barely any water with it. Kind of really getting into gory details about how best can we help you be compliant with this medication. So I definitely think it takes absolutely more effort with this change to get patients to take the medication and kind of take that extra time to do the counseling. But like Kathy said, we just need more data to see, is that enough to impact the chlamydia or, not. But I think one thing that's also reassuring is, remember in when we were talking about rectal chlamydia and the study in MSM, patients only had to take a couple of days in real world compliance for them to still have a superior microcure compared to azithromycin. So as long as your patient can choke down a couple of days, I think we'll still see an impact on disease. But
maybe
it's
like
a little harder.
Yeah, maybe more like 5 days. But
yeah.
Rayanne, have you gotten a sense from your colleagues at Planned Parenthood? Because this is a fascinating question overall, like how quickly clinicians change.
So at Planned Parenthood of Southern New England, we changed pretty much right away. I mean, we have pretty strict protocols that we follow. So we just changed, and patients are calling that they can't tolerate a week of doxy. It's happening for sure. And then there's this question of, okay, did you get down 5 days? Could we stop there, or do I need to give them azithromycin? So I guess that's a case-by-case basis on your patient. And then, I don't know, it's a work in progress for sure. Yeah, but no, we're doing doxy.
So I just want to thank everybody. We're a little bit past our time, and just want to really thank our presenters, our speakers, everybody. This was just a great session. And I hope everyone enjoyed it. Just remember that the evaluations for this meeting are going to be going out shortly. And you'll receive continuing education certification after you've returned your evaluation. So please, just make sure you send in that evaluation. It helps us for our next meeting, how we're going to run it. And if you have any follow-up questions that come up, feel free to shoot me an email, and I'll check in with all the speakers and answer whatever questions you have. But again, I just want to thank everyone for participating, the presenters, as well as all of you that registered. And I really just hope it was a great way to start our new guidelines that are out there. So thank you, everyone, and have a great day.